Thank you, Rika. Our next speaker is Professor Oskar Aszmann from the Medical University of Vienna. And Oskar has a lot of experience doing cervical reconstruction and done a lot of work for the rehabilitation of amputees. And we're very glad that he was able to make it today.
Thank you, Max. Thank you for inviting me to your symposium. Congratulations again to your professorship. I'm very proud of you. I know how much work it is. I have the privilege to talk to you about superhumans in the making. This is actually a title that is not really fitting this audience today. However, I think it fits the context we're talking about. I have been working like Paolo Sasso in the reconstructive world for about 30 years now. And about 15 years ago, I started to embark on this journey that I'm continuing today. So this is about maybe 12 years ago, these headlines went through the world saying 3 guys in Austria have basically become cyborgs after getting robotic hands. And I think of so much of what we have seen today is basically boiling down to where can we use all this technology to make patients happy, or how can we adapt the technology so that patients can profit from it. And so I remember distinctly when the first patients came to me, when as a reconstructive surgeon I was at the end of my wits, and I looked at the patient and I thought, God, you know, I have done everything I could do and still I do not get any functionality out of that hand. And I can give that talk to a bunch of hand surgeons in the room and they could all just nod and say, yes, that's true, I know my share of these type of patients. And here we have amputated existing limbs that had no function whatever, and we reconstructed them with very simple with very simple mechatronic means. And so after I've done these first successful patients, I thought, I know a lot of other scenarios where patients have useless hands and they could benefit from that technology. And so we focused on these 3 things. So this is either restoration after functional tissue loss, restoration after neural tissue loss, which is brachial plexus injuries or peripheral nerves, and then restoration after cognitive tissue loss, which is after a brain stroke or a brain tumor. To make sense of all this, I'll just drive you through 3 of these patient scenarios. This was my first patient about maybe 12 years ago. He had an electrocution injury and it ended up, he had 2 major tissue transfers, tendon transfers, nerve reconstruction, and he had no use of his hand at all. And if you look at that video, this is a student in the lab. This is 6 sensors, very simple EMG sensors picking up information and translating that information to prosthetic use. And we all know how that works. It's pretty easy, it's not rocket science, but if you look at the quality of hand function available, collateral grip, precision grip, power grip, open, close, rotation of the hand, we all know how that works. It's not really a big miracle today. Still, for a patient who has no function at all, this is a lot. So then I had a discussion with the patient. I said, are you ready to give up your own hand and have it replaced with a mechatronic device? And he just looked at the video and he says, sure, my hand isn't worth much at all. I don't feel anything, it can't do anything. And you can look at this, it says here MOT, and I put that in just to make enough space for the motors, so I would know that there is enough space for the mechatronic devices needed to drive the hand. So I remember when we have done this surgery, there was a lot of disgruntled people in the medical university where I am because they said, we cannot amputate a patient's hand. And we had an ethical discussion about that. But in the end, the patient profits from it, and we look at this, it's a bimanual dexterity. This is something you could have never done without this technique, without that option. Holding a glass, holding a bottle, having manual dexterity of both hands, this was impossible for that guy. So then we moved on from soft tissue destruction in the forearm and hand to neural tissue destruction. And there's a lot of patients, I'm sure also here in Sweden, who have had a motorcycle accident with a severe brachial plexus injury. So the hand's still intact, but the neural pathway is lost. So here, for example, is a young 16-year-old boy. He borrowed the motorcycle one time from his father and crashed a tree. And this is the effect. The neural highway from the brachial plexus down to the arm was lost. It's 350,000 nerve fibers going from the spinal cord into the arm and hand, and all that's gone within a second. So we reconstruct the nerves, and this is the outcome after 15 years. And you see it's a biologic wasteland. There is no sensation, no movement. And if you look at the rest of the body, he can flex his elbow, he has some shoulder stability, but the hand can do nothing. The problem is, even at the forearm level, there is no sensorial or no EMG activity. However, he does have a Thiel-Hoffmann sign, which means there must be some nerve left on the forearm. So we've done a standard tissue transfer, which is the gracilis muscle, which is this muscle, it's from the leg. We transplant this into the arm and thus establish a very simple EMG signal in the arm. And then the patient needs to have some brain training because we have no idea which axons actually make it from here to here. So we sit the patient in front of a computer screen, have a virtual training, so the patient can see what EMG he needs to activate, which spinal motor neurons needs to work to get the prosthesis going. And if that happens, then we have a hybrid hand, which is this kind of scenario where the only useful hand is here, which is not useful, and then you have the appendix. You remember the video where he couldn't pick up the small wooden block, and here he can pick up a baseball. Some patients want to take that hand home, and here you have 1, 2, and 3 hands, and with the third hand he's pushing the shovel. And so he knows that this concept's going to work, and he's willing to give up the hand. And then we again do a prosthetic reconstruction, which leads to an excellent type of hand function, which would be impossible with his own biologic appendix, if you will. The last scenario that we have been embarking on in the last few years is treating these patients with a brain stroke. Now, if you look at this, you had a brain stroke, and I think Max works on this as well. There is a spastic hand, meaning you have a cognitive loss in the arm. The patient may still be able to control the more proximal muscles, which is the pec major muscle, the triceps, or other muscles, but he has no control over the distal muscles. So what do? We do nerve transfers, and I call these cognitive nerve transfers, meaning we look at these nerves intraoperatively and we reroute these nerves that the patient can still address, and reroute these nerves to the level where he has no control over. That means in the end we have re-established cognitive control to muscles in the forearm. In some patients that's enough to get their hand going again to a functional levels. In other patients it's not enough, and in the end we also do an elective transradial amputation and then gather EMG signals that are useful for the patient. So he can flex and extend the arm, he can still do that, and then we gather these EMG signals to transport these into the prosthetic device. And with some tricks and algorithms, that's the outcome that we can achieve. And this is way more than the patient could ever do with his own hand previously. So there's pronation, supination, wrist extension, flexion, all that, to a high level of functionality. So if we look at that, we could all think cyborgs ahead. So here we come to the nitty-gritty details as to what really bothers us. And what bothers us that we all, as we sit here, we are sensorial beings. And what Max already said in his introduction statement, that to get to an embodiment, we need to have both an agency, meaning we need to be very clear as to what we want from the prosthesis, but also we need to have a sensory feedback. I've said already before, there's 350,000 nerve fibers coming from the spinal cord to the arm and hand. Now if you look at these red bars, these are the sensory axons, and only 10%, that's just a very small number, is efferent, meaning control signals. The majority of these nerves are afferent, meaning bringing sensory information back to the brain. This is a very small video of a patient who has a congenital deficiency of his proprioceptive system. It's a very rare disease, and even though the patient has a perfect motor system available to him, he has no proprioceptive feedback, and he cannot stand nor walk, and he cannot even crawl on all four, but he will fall over, and the only thing he can do is sit. Which means that without feedback, it's going to be very difficult to construct meaningful prosthetics. And this is all that we have at this time. And I think these are very funny movies, in fact. I think there's more to come. Okay. So concluding is, motor control is much more dependent on afferent feedback. We are sensorial beings, and we know our world by seeing, hearing, touching, and smelling. And all these are body-bound. And machines are thus helpers, gadgets, and in the end do not belong to us and do not allow a sense of embodiment. So we have seen some work from Paolo Sasso and Jamie Shore today, and so I believe that a transradial bilateral amputation is still the best scenario for a hand transplantation. And this is the oldest hand transplantee in the world. This was done about 20 years ago in Austria. And this video was done about 4 years ago. And this patient has a 2-point discrimination of 8 millimeters, thumb and index. He has great intrinsic control. He benefits from these hands dramatically, and I think it was worth the price of having immune suppression for such a long time. Now, in regards to bionic limb reconstruction, I think it does need all these three disciplines: robotic surgery and integration and interpretation of these signals. Because we need to close the loop from efferents and afferents. And so I think the way go forward, we've seen lots of work today, and I think this is the most important one, is to close the loop. And whatever effort we do, whether it's AMIs or transplanted work, and I'll show you also the way we want to close the loop, is of utmost importance. Now, one thing about whether it's TMR or RPNI, whatever it is, I think the good news is that if you look at this, there's only about 7,000 spinal motor neurons responsible for forearm and hand, and only about 1,000 for the intrinsics. So that when we do nerve transfers, we can effectively transfer that information into these muscles to a very high degree. Which means that from these muscles, in whatever way we transfer that information, we can pick it up and then transfer it into a mechatronic movement. So this is the way to close the loop. We have an efferent control, and then through a dermal transplant, we've seen the work from Srinivasan today, close the loop for an efferent pathway. And I think this is definitely the way to go forward for these type of patients. What we wish to have is this type of an interface where we basically just connect our brain to a certain machine. We're not there yet, but I think in the near future we'll have some avenues where this will be possible. So defining limits, how much body is necessary and how much machine can we tolerate. This basically comes down to the question is what the human body is. Is it 46 chromosomes that have been incarnate in our human body through which we express ourselves? We permeate it and it permeates us. And this body that we have serves us and others not as an avatar, but as a real body, tangible, haptic, vulnerable, and unique. I think this is an important question because in the end, we also have the philosophy of a transhumanism, meaning that we can have an enhancement or transcendence of human abilities and restrictions to the application of technological tools, the merging of biological matrix with technological instruments. And again, this should not be only a mere application, but the merging with our neural network. Because I think this is the only way to get to a true embodiment, either through augmented reality, virtual reality, and AI. Now, if we look at this patient, and this is one patient, I think also from Richard Brannemark, with 4 osseointegrations after having lost both legs and both arms, how will he connect with his children or his wife? Will it be through his limbs, artificial limbs, or will it be through the membranes of his body? And I think this picture says it all, because machines in the end we only control but the body we inhabit. Thank you.
Thank you, Oskar. We have one question from the online audience.
Yes, and the question is, how useful is osseointegration compared to socket for bionic reconstruction for a severe trauma brachial plexus injury patient? And follow-up question, how much use might be gotten from internal electrodes then?
So I think in regards to osseointegration, it's not a question of how the accident happened or where bionic reconstruction is happening, but the level of amputation. I think for transradial patients, a regular socket suffices, is good enough. For transhumeral patients, I think this is the ideal application, I'm talking upper extremity only here, is the ideal scenario, because any socket has a soft tissue around the humerus and thus will not be able to have the stability that we need. In regards to implants, I think there is a great opportunity to have implants also in that same scenario, because we can have lots of targeted muscle transfer for transhumeral cases. Now, Cynthia Chestik has talked about TMR or RPNIs in the forearm, but when you think about it, for a distal transhumeral case, you have lots of originally innervated muscles in the forearm that will provide a lot of impulses that you would need to drive a device. So I think the best scenario, the best indication for an osseointegration upper extremity is a transhumeral amputation, and also this is the best scenario for the use of implants.
Thank you, Oskar. In the interest of time, I'll make a case for osseointegration at the transradial level during dinner. But